Good afternoon, everyone. It's wonderful to see you all here. My name is Jia Honglin. I'm a nurse practitioner and a PhD student from Taiwan. First of all, I want to thank the organizer for giving us the opportunity to share our recent findings on the topic of cognition, cognitive impairment, frailty, and emergency hospital admission among older patients. We conducted our study within the emergency department of a medical center in Taiwan. I have the great privilege of collaborating with Dr. Xianhao Huang, an invaluable partner in our research journey. This slide shows that I have no conflicts of interest. Next, you can see the outline of today's presentation. Let's begin with some essential background for our study. There are two main streams of current research: old adults with cognitive impairment and old adults with frailty. Among the older patient population in community settings, prior national research revealed the prevalence of cognitive impairment only is about 25%, and both cognitive impairment and frailty is about 8%. Then, both cognitive impairment and frailty had the highest prevalence of dementia, depression, cardiovascular disease, and disability. The two conditions often increase the risk of adverse outcomes and complex healthcare needs of older adults. Older people experiencing both frailty, cognitive impairment, had a great risk of repeat falls. Additionally, older adults with cognitive impairment are at risk of developing delirium in the emergency department. Since past research primarily focused on older adults in living within their communities, not in emergency department settings, our objective was to investigate how cognitive impairment and frailty, separately and together, affect hospital admission through emergency department visits among older adults. We hypothesized that the presence of frailty and cognitive impairment, either individually or in combination, would elevate the risk of emergency department visits, leading to hospital admission. Now, let's take a look at the methodology of this study. For our study design and setting, we've carried out a prospective cohort study to investigate the relationship between cognition, frailty, and healthcare outcome among older adults. This setting was in the emergency department observation unit of a medical center. Our approach was to check the cohort further incidents of hospital admission after the cognition and frailty assessment in the emergency department. In this setting, from March to August 2022, we conducted cognitive function and frailty assessments on older patients, aged 65 or older. However, to minimize the bias, we excluded the 6 criteria of patients listed on the slide. Our follow-up data was then collected from the electronic medical records. From our study flowchart, you can see that for the exclusion steps, our study included 1,151 patients. Our study included 1,151 patients to analyze further. Among them, 69% were admitted to the hospital, while the rest was discharged. We are focusing on certain variables. For the outcome variable, we look at whether patients' emergency department visits result in hospital admission. On the other hand, our primary interest lies in predicting the outcome based on the cognitive function and frailty. However, we also take into account potential confounders, such as demographic data and some clinical indicators. Our study employed short portable mental status questionnaire (SPMSQ), whose reliability and validity have been verified. This 10-item tool covers orientation, memory, and attention tasks. Scores can range from 0 to 10. One correct answer scores 0, while each error scores 1. If the SPMSQ score is 5 or higher, we would identify that as cognitive impairment, whereas a score of 4 or less suggests no cognitive impairment. On the other hand, in assessing frailty, we utilize the Clinical Frailty Scale. This 9-point scale effectively measures varying frail levels and merges visual and textual clinical descriptions. 1 point indicates a highly fit individual, while 9 points show that the patient is terminally ill. Most importantly, the scale allows us to classify patients based on their recent baseline functioning using informed clinical judgment. Based on the Clinical Frailty Scale, we further categorize frailty into 2 groups in our study. The first group includes the CFS scores ranging from 1 to 5, and this group represents patients that are non or pre-frailty. In the other group, the CFS scores range from 6 to 9, and it represents that patients are frailty. Our research found that, first of all, the average age of participants to be 78 years. About 74% of participants were assigned to mid-level triage. It's also noteworthy that their vital signs, including temperature, pulse rate, and blood pressure, remain stable. Secondly, in the category of cognition and frailty, 51% of total participants were intact, no frail, and no cognitive impairment. The rest either had cognitive impairment only, frailty only, or both, which is a considerable proportion. Lastly, in the logistic regression analysis, we used 2 models. Model 1 is an adjusted model, and Model 2, which adjusted the age, gender, and triage. The 2 models show that having cognitive impairment alone did not significantly change the odds of hospital admission following emergency department visits. However, in Model 2, the odds ratio of both cognitive impairment and frailty is 3.7, much higher than that in Model 1. All that is to say, it's clear that the odds of hospital admission are significantly influenced by the presence of frailty, whether alone or in combination with cognitive impairment, and this relationship remains even after adjusting the age, gender, and triage severity. For some limitation of our study, first, this study was conducted in a veteran general hospital, a single urban medical center, which might result in a higher proportion of older veteran patients. Secondly, we excluded unconscious or uncooperative patients, which would potentially limit the generalizability of the result of all older individuals visiting the emergency department. Lastly, as a prospective cohort study, we can definitely confirm the causal link between cognitive impairment, frailty, and health outcomes. To wrap up our study, we found that older adults showing both cognitive impairment and frailty have a remarkable risk of hospital admission following the emergency department visit. Therefore, in emergency departments, early recognition of these conditions in older patients is crucial. Essentially, we need to focus on managing cognitive health and frailty to lower avoidable potential hospital admissions and allocate emergency resources more efficiently.